Next, Robert Vogel is joined by Dr. Donald Lloyd-Jones, professor and chairman of preventive medicine at Northwestern University in Chicago, Illinois, to discuss multivariable risk models, Framingham, lifetime risk, and beyond.
Welcome to ACCEL, Donald.
Thank you, Bob. Good to be with you.
The Framingham Risk Score is a global risk index designed to estimate the 10-year cardiovascular risk of an individual and is really the core of screening patients for the likelihood of future cardiovascular risk. It's the granddaddy study. It started, I believe, in 1948.
That's correct.
Been more than 1,000 papers published from Framingham. Is that correct?
I think they're closing in on 2 now.
2,000 papers. That's quite a bit. The Framingham estimate score gives you a 10-year risk for an event. Is that the best way to go? Should we go to a lifetime? I mean, if you're 20 years old, you can't be high risk.
Well, I think it's a really important point. As you know, age is the heaviest weighted covariate in the Framingham risk score, which also includes gender, cholesterol levels, HDL levels, blood pressure, diabetes status in some formulations, smoking, and hypertension, and whether you're treated.
Age and gender are the 800-pound gorillas in that formula.
Absolutely. And so as you're indicating, it's very difficult for a younger person to get a, quote, high-risk estimate, at least over the next 10-year risk estimation cycle. So the way I think about this is that I think 10-year risk estimates and longer-term or lifetime risk estimates actually provide very complementary information. I don't think we need to replace 10-year risk estimation with lifetime risk estimation, but it's a much more useful, I think, context for a younger person where you're never going to tell them high-risk information, even in the setting of pretty substantial elevations in their risk factor burden, simply because they're young. So taking that longer horizon perspective, I think, is very important for risk communication.
What is high risk? What is low risk? We talk about 10 to 20%. Some people have said 6 to 20%. These are arbitrary cut points. What's your idea on this?
Yeah, I think it's a very important question, and I also think it's a moving target right now. We've seen in the last few years some very nice papers looking at cost effectiveness now in the era of generic statins, and clearly that's going to move our bar down, because if we're seeing very good cost effectiveness, for my money, certainly at a risk threshold of 10% for definite treat, and in some papers maybe even as low as 7.5%, I think those are regions where we should be starting to get more intensive with our preventive therapy, and I think we're specifically talking about statins here.
The Framingham approach uses the variables that we've talked about. Other global risk scores add other variables. Are any of them worthwhile?
Yeah, it's a great question. I think there are 2 aspects to, quote, newer risk scores. One is which variables they include. And, most typically recently we'll see things like family history included and some of the scores, things like CRP or socioeconomic status. At that point, you're really adding pretty marginal information from what I see in studying this. I think the other consideration, though, in these newer risk scores is to think about whether the endpoint that it targets is really an endpoint that's of interest. Some of them only focus on cardiovascular death, and I think that's a little too restricted. Some of them include revascularization, and that's a little messy because it's a very geographically dependent phenomenon.
And some include cerebrovascular disease.
Right, and I think that one actually is important. I think we should expand from a focus solely on coronary heart disease and include fatal and non-fatal stroke as part of our endpoint, because it's particularly important for women as an early endpoint.
Some of the European approaches utilize high-risk areas, low-risk areas. Should we change the score, make it geographically varied? We have a stroke belt in the south. I'm from Colorado. We like to think of ourselves as healthy.
You have the healthiest state in the nation. Congratulations, although I think Vermont gives you a run for your money. But, I think it's a very important question. Both geography as well as race and ethnicity do cause us to interpret the risk scores a little differently, I think. The original Framingham score was derived in exclusively Caucasian population. It turns out that transports quite well to African American populations as well, with good discrimination and good calibration. But for groups like Hispanic Americans and Asian Americans, it does tend to overestimate risk, given the same risk factor burden. So there are some kind of fudge factors and calibrations that need to be considered if you're applying this to a non-Caucasian population.
Framingham had an offspring study where we actually knew what the parents died of because they were within the study. What did that teach us about the hereditability of coronary heart disease?
I was actually at Framingham when we did this paper, and what we found was that even after you adjusted for the personal risk profile of the offspring and the potential heredity that had come through cholesterol and blood pressure and diabetes and so forth, there was still an independent twofold excess risk from having a parent who had had cardiovascular disease before age 60. So as things go, that's a relatively good independent odds ratio or hazards ratio. But it turned out that when you actually apply that in this sort of NRI framework, it doesn't move that many people. If the offspring was already low risk because of their personal profile, it didn't make them high risk to have a parental history. And if they were already high risk, it certainly didn't make them low risk if they had an absence of parental history. In that middle or intermediate risk group, it'll move a few people. So it's potentially useful information for an individual.
And so NRI is Net Reclassification Index. It's what a variable or parameter does in terms of moving especially intermediate risk individuals into the categories that we're really interested, high or low risk.
Exactly right.
So we're at the ACC meetings. We're about to hear about the HPS2 Thrive data on niacin, which suggests that maybe the HDL story is more complex than perhaps what Framingham suggested in the beginning, which was that HDL and coronary heart disease have very close inverse relationships. What's the difference between a factor and a marker?
I think this is very important to understand, and as you pointed out, Framingham was really the first study to put HDL on the map in an observational setting as a risk marker. And I think it remains a helpful marker of risk. It integrates potentially a lot of metabolic information and other things, but I think what these recent studies with HDL cholesterol raising attempts show us that HDL is not probably a causal risk factor, because when we try to intervene and stuff more cholesterol into that HDL particle, it does not seem to be improving outcomes, and certainly not improving outcomes over and above statin therapy. So I think that's an important distinction, that HDL can still help us understand who might be at risk, but it should not, at least at present, probably be a target of therapy.
Is it possible that HDL is a marker simply because it goes with other things which cause coronary heart disease, such as smoking or lack of activity or bad diet or things such as that?
I think that's exactly right. I think it's a nice integrative marker of physical activity, sedentary lifestyle, diet, obesity, many of the other things you mentioned. Absolutely.
Perhaps like CRP.
And even inflammation.
Yes.
Exactly.
Diabetes is considered a coronary heart disease equivalent. In fact, in the Framingham approach, once a patient has diabetes, then we really don't calculate the scores per se. What do you think on that subject?
Well, so I'll defend Framingham for a second, because actually it is there in the original Framingham risk score, but it was modified by the ATP3 panel because at the time the thinking was that an individual with diabetes was at the same risk as someone who already had coronary disease. I think since ATP3, further literature has come out that we don't actually feel that that's the case. But important to say that diabetes is still a very important risk marker and risk factor in people who have it, and that once a diabetic gets coronary heart disease, their outcomes are much worse. So diabetics remain a special population that I think we need to consider, not just their risk, but also the outcomes in that group.
Don, I'm going to put you on the spot. Framingham is one, if not the most important study in cardiology to many, certainly from a preventive point of view. Sum up what it has meant for the practice of cardiology today.
It has been an incredibly important study. As you pointed out, it started in 1948. It was tagged as one of the great achievements in science of the 20th century, and I would certainly agree with that. I think that the understanding that this construct of traditional risk factors that Framingham has put on the map and how they interact to cause disease has been a major step forward in helping us understand both targets of therapy, but also finding individuals who we think are at risk. So it really has created the whole construct of the notion that we should base the intensity of our preventive therapies on the absolute risk of the patient. And I think Framingham set that table beautifully, remains really the bedrock of our preventive approaches. Not to say that we can't do better, though.
Don, thank you very much for joining us at ACCEL.
It's been my pleasure.